Okay, good morning. We good to go, Chief? All right. We're going to be going over Peds today. We're only going to do half the lecture today. Nico is going to touch the other half for you, I think, on Friday. And then he'll be introducing some Airway stuff as well. The first part of this, if you've ever been around kids, is pretty self-explanatory. And then we'll get into some of the actual medical conditions as we go. Does everyone online hear me okay? Perfect. Okay. Hey, Chief, the clicker's not working.
Put your mouse on the PowerPoint and just click right in the middle. There you go. Just click, and now it'll work. Unless is it turned off on stuff?
Yep. All right.
There you go.
Thanks, Chief. All right, so there's some specific things we're going to talk about with Peds. Everyone gets really nervous on Peds calls, and I understand why. The book seems like it hammers pretty hard that they are not just like adults for you guys, and it's a debated lecture depending on where you go. There are definitely some physiologic differences, and there's some things specifically that we're going to look at in Peds. But the best advice I can give you before we dive into this is if you have that Peds call and you're the lead provider on it, take a step back and try and take in what's going on. Remove yourself from the problem initially so you're not too close to it. So we're going to go over upper airway obstructions, lower airway reactive diseases, respiratory distress, failure and arrest, shock, seizures, SIDS, and gastrointestinal disease. Like I said, we won't touch on all of these today because Nico will hit some in a couple days, but we'll get through a lot of it. With kids, we've also got the big idea of abuse and having to report that. So that's actually at the end of this. We're not going to touch on it today, but that's obviously a major factor in pediatric care. Healthcare implications, you're going to have a lot of our pediatric population is going to have some kind of special needs if we're running on them. And then we'll have our kids that are generally sick or hurt as well. When you get to the patients that have all the technological advanced stuff at home, because they have some kind of special needs, your best resource is going to be their parents. They're going to be really well versed in how to work the machines. Trauma is a major factor on kiddos, one of the number one killers of kids. So trauma and respiratory are going to be our main ones. This slide, I'm actually not sure why it was in here, Chief. It just referenced the other chapters. So there are pediatric patients in other chapters of your book, I guess. Special considerations in trauma are for these patient classes. We're not going to dive too much into them today. You've touched on them in your other chapters already, or will in your chapters coming up, I'm not sure. All right, so Peds are a relatively small amount of the calls we run, which is part of the reason why we're so uncomfortable with it. It's part of the reason why we're not good at pediatric IVs, why it's frustrating for us, along with the fact that when we see kids, they're usually pretty sick, and kids aren't supposed to get hurt, and kids aren't supposed to die, and that's all very stressful. Pediatric nurses actually do really well in a lot of the stuff because they see it every day. They're much better at Peds IVs and things. We get lucky a lot of times where the kid doesn't actually need an IV, or if they're really sick, we move right to AO. And so we have this gap in our training where we're not very good at Peds. Naturally, if you're going to have a pediatric call, you're probably going to have parents or care providers on scene, and they're probably going to be pretty flustered. So somebody, if you can either denote somebody to them to help manage them, help get history from them, or find a way to have them assist in your care, call will go a lot smoother. So something I like to do is just have them go write down all the patient information, get them out of the scene for just a second, out of the circle, and then we can deal with it, and then bring them back in, let them hold kid's hand, let them comfort the child, things like that. And once again, children are not simply small adults. Welcome, Max. They do have special needs that require assessment and management strategies, but at the end of the day, your guys' skill is the same. It's just how you introduce it to the child. You may have multiple patients to treat. Once again, mainly your parent or the kid's parents. If you can get the parent to calm down, it usually helps the child. And if you can explain to them what's going on and get them at a level to where they can help you, then you're going to have a lot better management of the child. So remain compassionate and calm and professional. It's usually easy to get an adult to calm down, but it's a lot harder when it's their kid to get them to calm down. And then once again, allow them to participate in the care of the child. So sometimes that's helping carry them, sometimes it's just holding their hand, whatever is going to be beneficial for you. While you're assessing, if they're not critically sick or critically injured, allow them to sit on the parent's lap or let their parent hold them. It'll help them feel comfortable. If they are really sick or critically injured, then obviously we got to go. Infancy is defined as the first year of life. Like I said, these first bit of slides are not as exciting, so we're just going to breeze through them. 0 to 2 months is your, or 0 to 1 month is your neonate period, and then 0 to 2 months. This is going to get into how they act a little bit. So, infants younger than 2 months spend most of their time eating, sleeping, crying, pooping. They are usually easy to arouse, but they don't have a lot of, they're not super interactive. And if you guys, I think most everyone in here has kids. Max just was a kid, so. I don't think any of this stuff's going to surprise any of you, so we'll just breeze through it really quick. Their head control is limited. They're predisposed to hypothermia because they've got a big amount of body surface area to their actual mass. Crying is one of their main forms of expression. There is a difference between a crying kid and an unconsolable kid, and we'll touch on that a bit later. The saying a crying kid is a good kid is good for us because they're breathing, but then there is another step of are they consolable or not. 2 to 6 months, they're going to spend more time awake. They become more socially interactive. They recognize their caregivers a lot better. They get a little bit more clingy to their parents. Some voluntary smiles and eye contact. And then by the age of 4 months, says they should be able to hold their head up. That's going to be a little different on every kid. But if a 6-month-old is not holding its head up or isn't able to, then that should prompt you a little bit more. Healthy infants have a strong sucking reflex because that's how they eat. So, vigorous cry, lack of eye contact. Lack of eye contact would be a depressed mental status. So they should track you pretty well. They can hide from you, but either way, if they're just kind of gazed, then that's an issue. If they're tracking you or hiding from you, that's a good thing. 6 to 12 months, they can sit up, they can reach, starting to crawl, they're teething, they're putting anything and everything in their mouth. And that the 6 to 12 month range is a big portion of that, but that doesn't go away for a lot of the rest of the pediatric years. These kids, we get a lot of the calls for the kid that put a piece of carpet or something in their mouth and mom's worried. They're also the kid that's going to get a hold of some money and put that in their mouth or anything else they can find. So foreign body aspiration and choking is actually a pretty high incident in this age group. Babbling's common. By 12 months, they should be learning some words. May not be interactive with you much, but they should know some words and have a vocabulary. Probably cry if they're separated from their parents. Some kids are better with that than others. Like my daughter did not like guys. Talk to any girl in the world, even if she'd never seen her before, she did not like guys. We are going to go over the pediatric assessment triangle later. That's going to be a really helpful tool. I don't know if you guys have seen that before, but that's one of the better pediatric tools I've seen. And then give respect to the patient's caregiver if they're saying something's wrong. They're with the kid a lot more than we are. They are going to be a little bit more invested in the problem as well, but definitely take in what they're saying and try and hear them out. Along with that, parents are a good resource for how many diapers the kids have gone through, how well they've been eating, if they think they've been running a fever, sleep patterns. Kids younger than a year are pretty dialed in their day-to-day. So by 6 months, they should be making eye contact. Try and warm the stethoscope up if you can. If the kid's uncomfortable, you can have parents raise their shirt, let the kid play with the stethoscope a little bit, especially as they get older. So be opportunistic with your examination. So if the kid's not crying, it's a good time to listen to lungs. If they are crying, you may try something else first. It goes into it a little bit later, but they want kids to, and I'm not really sure why, and Shane or somebody else you may know, on little kids, they want you to start your assessment from toe to head as opposed to head to toe. And I'm not sure why your book gets into that, but it was very specific on that at one of these slides. So. Yeah, sure. I think it was over 3. They want you to go back to head to toe or something, but I don't know. It might be an age for you guys to know for your test. Can't imagine there's more than one question on it, but if a young infant starts crying, you can give them their pacifier. Says a glove finger works. I'd be real cautious if they got some of those razor teeth in there, putting my glove finger in their mouth, but to each their own. Jingling keys or shining of pen lights are usually good for distracting an infant, or if you can find their favorite toy or their stuffed animal or blanket. A lot of kids are going to have some kind of security item, so whether it's a blanket or a bear or whatever. Toddlers, so until age 3, you're called a toddler after your 12-month period. So they start becoming more people. They get interactive, they're playing, they want to wrestle. They can almost explain what's going on with them, but not really. Potty training usually starts in here. They should be able to know their major body parts. They can talk to you. They're eating whole foods, they're chewing. For all intents and purposes, they should be pretty easy to assess, other than they're going to be worked up and scared. Toddlers' minds developing rapidly. They say kids this age are working at a genius level. The amount of information they can take in and process is exponential compared to us, which is obviously important for their language and things as they grow up. They start to understand cause and effect. Their balance and gait improves rapidly. They also fall rapidly still. So they get really brave and then they run down the hall and they don't really know fear yet. Persistent crying, we kind of touched on this already, can be a symptom of serious illness. So if the kid's unconsolable and mom can't get it to stop crying, or dad can't get it to stop crying, or whoever's caring for it, then may take it a little bit more seriously, because they're probably trying to express that something's wrong and they just don't know how. Because they're starting to eat, they have an increased risk of aspiration and choking. Specifically when they start getting into meats and overloading their mouth. I don't know if all kids do it, but my daughter thinks she's a chipmunk. So everything goes into her mouth before she starts chewing. And then you can examine them with their child on the parent's lap again. Be creative with toddlers. They like to have fun. So if you can find a way to distract them, blown up glove, like you said, your keys, a pen light, something that shows them that you're not mean, you're just there to have a good time with them, can help. If they're really sick or really upset, it's probably not going to do you a ton. But those middle ground cases to minor cases, it'll be really helpful for you. We don't have any, but I know they make some blow-by oxygen bears that'll actually, it's just a stuffed animal, but you can blow oxygen through it, so it's an easy way to get blow-by on kids this age. And then whatever is going to be the upsetting part of the exam, try and do it last. So if you've got to get a blood sugar or you need to start an IV, you may not start with that, especially if you're trying to win their trust. It says they would have the parents press on the abdomen. I don't know if I'd do that. I might have the parent lift up the shirt, but I want to feel the abdomen and see what's going on personally. But that's what your book says. So 3 to 6 years old, they're starting to understand directions a lot more. Approaching and into kindergarten age, they're identifying painful areas. They should be able to hold a conversation with you. They should be able to tell you what hurts. Not necessarily why, but they should be able to express to you exactly what's going on. Risk of foreign aspiration continues to be high. Still playing with money and seeing how things taste. Take advantage of their curiosity. If they are medically stable, you can offer to let them use the stethoscope, bring it back, show them the monitor. It's all very exciting for them. Simple choices, so avoiding yes or no answers, which is easier said than done, especially for us. Many of our assessment techniques go off of yes or no, so it's really hard to leave a yes or no question to a kid, and since kids like to say no or like to just say yes to something, it's difficult to get an accurate assessment from them. Parents are still going to be heavily involved here, but try and be creative in how you ask the questions. 6 to 12, they're starting to think in concrete terms. They can make sense of things. They help take care of themselves. They should be relatively self-sufficient at this point. And then the school-age kid can understand between emotion and physical pain. They give explanations. You can give appropriate choices and control whenever possible. Oh, rewarding. Not a little bit with the younger kids, toddler age and up. Reward is going to be huge to them. So especially in the school-age kid, because they can process so much of what's going on. But even in the toddler age, positive reinforcement is going to be really, really big for them to help win their trust and move them along. 12 to 18 years old, think of them as small adults. They start to be dosed in a lot of things at the adult size. They have the ability to conceptualize things that are going on. They can have full conversations. They do begin to struggle with emotional issues, getting into body image, sexuality, and peer pressure. But as far as medically, they should be able to explain to you what they're feeling. And then definitely don't write them off just because they're young. Especially nowadays, kids are starting to have a lot more cardiac things and getting into a lot of other facets of life that are causing issues. Especially talking with like energy drinks and things, kids are having heart attacks. They're just linked energy drinks to a massively higher incidence of stroke. So like 500 times higher or something. So, definitely just don't write these kids off. Give them the time of day. Treat them like adults. If you treat them like an adult, they'll give you respect back usually. This wants to address concerns and fears about lasting injuries, especially cosmetic stuff, because they're usually so insecure. They need that affirmation that it's going to be all right. Don't lie to them either, but especially like if it's a girl, don't tell her that her face is all messed up. When communicating with them, just like anybody else, find their interests, see what they do, kind of distract them from the problem, and then it wins them over again as well. Respect their modesty. There's some hard questions, especially with young females, that make them really uncomfortable dealing with their menstrual cycle, sexual activity, and things. Some of these are best answered not around a caregiver, but they are questions that do warrant being asked, especially if they've hit puberty age, which they should have by here. That's definitely, if you get into abdominal things, or if you think it's a toxin, those are all very valid and warranted questions that you need to get into. Even if it appears like a syncopal episode, maybe they had a heavy period or things. So it's something we need to assess. It's not always the most comfortable question to ask, but there's usually a time you can find to do it. If there's friends on scene, they may want their friend to remain with them. Depending That's your guys' choice as a crew, but it'll probably help them stay calmer if one of their friends comes along, especially if you can pick out that one good friend that can kind of stay in control. And then never let your guard down regarding scene safety. So children's bodies grow and change very rapidly. There are some distinct anatomical differences that we'll touch on. They can create some difficulties assessing them, but if you understand them, it's pretty straightforward. So a child's airway is smaller in diameter and shorter in length. A child's tongue takes up more room in the pharynx, and the airway tends to be a little bit more anterior. Their epiglottis is floppy and narrow. Larynx is high, more anterior. Trachea is small in diameter. You guys aren't going to be getting into intubating, but this comes in really heavy when you talk about intubating a peds. They're usually very pliable, they're flexible, so it's actually not necessarily a hard tube, it's just a much smaller target. And that's going to be the same thing for you guys when you deal with iGels and ventilating in general. There's some anatomical differences, but because they're pretty adaptable still, they're actually relatively easy if you manage it properly. Mm-hmm. Yeah, Shane said think of it like a funnel. It's a good, I've never heard that. It's a good idea though. So here's two pictures going into the difference between a child and an adult. This is specifically dealing with their tongue. Infants use their diaphragm rather than their chest muscles during inspiration. This is what makes them a belly breather. We use much of our chest in our expansion. So if they are having an abdominal issue, it can affect their breathing, specifically if their abdomen is distended or if there's a lot of pressure built up into it. And then the tongue taking up more room in the oropharynx can cause you a blockage as well. Tissues of the lungs are more fragile, so in disease processes, they're more fragile. They're going to have more issues. Ribs are more cartilaginous, so they are more flexible, which is good. They may not break as easily, but it also means that you're going to have more impact into the thoracic cavity if you have a traumatic situation. So substantial compression into the chest can damage your vital organs in kids, even if you're not feeling crepitus and things. So just keep that in mind. Most of their bones are very pliable and flexible. The respiratory muscles in a kid are very immature. They definitely will tire more quickly. So they can breathe and breathe and breathe, but then they don't have that muscle mass that we do, and so eventually they're going to get tired and then they're going to quit. Kids' main problem is usually airway related. So airway, trying to stay on top of it. And then their functional residual capacity is lower. So when they reach that point where they're at that breakover, where they're no longer able to keep up with their breathing pattern because they're tired, their residual capacity is much smaller, so they're going to start dumping a lot faster. This is one of the reasons, along with some others that we'll touch on later, that kids can maintain really long, and then all of a sudden they just drop off. Well, it's because they were basically already dropping off, and we just didn't catch it. Here's your respiratory rate for peds. Obviously it decreases as they get older, as their tidal volume expands and as they don't need their oxygen capacity is a little bit different. These are good numbers for you guys to remember for your test. Probably a point or two on your test somewhere. So. Gastric distension can result in hypoventilation, increased risk of regurgitation with aspiration. So if their belly gets really, really full, it's going to, because they're diaphragmatic breathers, it's going to impact their ability to expand their chest. Or to expand their thoracic cavity, rather. By that same token, if they end up vomiting, then they're going to have an increased risk of aspiration with that. So keep the nares clear, avoid hyperextension of their neck, keep the airway clear, and use care when managing the child's airway. They talk about using soft suction casts to suction out their nares, as well as a bulb syringe if you need. So just try and get it clear. Infants are very susceptible to hypoxia again. So they have decreased reserves, they have an increased demand, and they're easily fatigued. So the bulk of sick kids that we run on, medically speaking, are going to be respiratory in nature. So please keep that in mind. Please get on it earlier than later. I can't stress that enough, and I don't think this can either. If you look at kids' problems, they're typically, put congenital stuff aside or special needs aside, they are airway problems, traumatic problems, and toxins. And you should be able to funnel most issues into one of those three. If you can't, then you need to start really thinking about something different as far as like what's going on with them. But most of your problems are going to fall into one of those categories pretty broadly. Cardiovascular system, how you guys doing? You want a break? You good? Only half hour in. Okay. Children rely on their heart rate to maintain their cardiac output. Infants' heart rate can beat 200 times a minute or more. There's formulas later in life that you take 220, subtract your age, and that's roughly your maximum heart rate. It's not 100% accurate, but it gives you a relative idea. So this is part of where that comes from. Kids can beat about 200 to 220, it says. Anything past that is not going to be a pathologic thing. They have a larger circulating blood volume in proportion to their body. So not necessarily more blood than an adult, just more blood for their body size. They also have smaller areas for that blood to go into. So in trauma, keep that in mind. They can maintain their blood pressure for longer periods of time, but then once they do dump, they're going to completely drop off the end. So really look for early signs of compensatory shock in these kids, because as soon as they get past that point, you're going to have a really hard time catching up. So any kid that presents tachycardic that's past what you would suspect for how worked up they are, suspect shock. If the kid becomes bradycardic, usually suspect hypoxia, and usually suspect that you are way behind the 8 ball, because they've already passed their ability to keep up with their breathing pattern, and they've already gotten rid of their oxygen reserve. So you're really, really far behind. Hypotension in a child often indicates cardiopulmonary arrest. These are good kids, actually, as well as adults, and I'm not positive. Pete, can the Advanced do end tidal? Yeah, okay. If you have, 1 second, sorry. If you put end tidal on these kids and you see their end tidal just start crashing, they're going to arrest like imminently. So just something to put on the side. Go ahead.
I was just curious in regards to we're talking about bradycardia, but you're suspecting more of a respiratory situation. In regards to giving fluid, that chain, I mean, I know typically we give 20 ml per kg, but if it's a cardiac event, we would soften that a bit, right?
You're probably still going to give it.
You don't want to overload the heart.
You don't want to overload it, but odds are that it's either third spaced or it's not there. And you have to look at your physiology too. I mean, if their lungs are wet, then be careful. But by the same token, if the excuse me, if the tank's not full, it can't circulate that oxygen. So it's going to be based on your problem, but especially a single bolus isn't going to hurt them. It's going to be case by case, but I definitely wouldn't steer away from it just because you think it's cardiac. And then with that said, especially the younger kids, they shouldn't have heart problems in theory. I know that's changing a little bit, but they shouldn't have heart problems, so it should be respiratory or toxin or trauma. As they get a little bit older, you can consider cardiac more, or if they've gotten into toxins or energy drinks and things. But generally speaking, kids don't have a ton of cardiac problems. That's not to say it won't happen, but signs of vasoconstriction include weak peripheral pulses, delayed cap refill, and pale and cool extremities. And we'll touch on that a little bit more aggressively later. The brain and spinal cord are not well protected in kids. Their neural tissue is really, really fragile and prone to bleeding. So although they bounce well, when they do get hurt, they usually get hurt pretty good. Subarachnoid space is smaller, and bruising and damage to the brain can be a result of something as simple as head momentum. Their head is significantly bigger in proportion to their body. So in terms of spinal fractures and head injuries and things, the head tends to take a brunt of it. The pediatric brain requires twice the cerebral blood flow as an adult, which puts them at an increased risk of hypoxia. So they are already under twice the demand that we would be, and then you start making them hypoxic, and they are at a significant risk for an anoxic injury. And then head injuries are greatly exacerbated by hypoxia and hypotension. I think that's self-explanatory. Spinal cord injuries are less common, but still something to consider. Bones in children are softer and more porous until adolescence. Incomplete fractures are common, and I actually think this slide's funny because it says to treat every sprain or strain, although it could be a fracture, and I think we do that in just about all of our populations. But I thought it was funny that they specify it in Peds especially. So definitely immobilize the injury. Talking about the epiphyseal plate, that's the growth plate in their leg. So you guys are going to be able to do IOs. So think about that when you're starting your IO. That's the one big area we can hurt Peds is if we damage their growth plate. And it'll cause bone growth abnormalities and deformities. So as if it's not stressful enough to be working a kid, and then you've got to remember the differences in the IO procedure, and now you have to remember that the growth plate is there as well. So just take that step back, take a breath, and move on. During infancy, the anterior and posterior fontanelles are open. So remember that they're going to be a little bit of increased risk for damage in those areas. And then know that if it's sunken, it's dehydration, and if it bulges, then it's increased intracranial pressure. They should be closing around 18 months. And then infants, because of the size of their head, they experience a lot of heat loss. So hats for infants are really important. This is another area in EMS as a whole that we're not as good about, is keeping our patients warm. So especially kids, really think about keeping clothes on them if possible, keeping them bundled. Special care must be taken when positioning a child's airway. If they're younger than 3, thin padding underneath the back. And then if they are 3, try and just do a folded sheet underneath the occipital area. It should put them in a sniffing position. Excuse me. And we just talked about that. Their abdominal musculature, much like their chest, is still really immature. So anytime they get hit in the stomach, they're at increased risk. Splenic and hepatic injuries, I know we talked about this when I touched in the gastro chapter, but they're going to be at a really increased risk for that just because they don't have that abdominal wall. So kids that are starting to ride bikes and things take a handlebar to the gut and they can get a spleen or a liver lac, and then before you know it, you're behind the 8 ball because they're bleeding. So as much as I said, I think most people have been around kids in here, so we've seen them take some nasty falls and they get up and they keep going. But if things aren't adding up, start counting those red flags in your head and then take them into appreciation. Multiple organ injuries are common, especially in the abdominal area. Kids have thinner and more elastic skin, larger body surface area, and less subcutaneous fatty tissue to keep them warm and protected. So this is going to lead to more dehydration, more hypothermia, increased burns, increased risk of environmental issues. So. All right, metabolic differences. Infants and children have limited stores of glucose and glycogen. So where we can go for quite a while, they're going to be much more rapidly depleted, especially if you're dealing with a diabetic. Glucose produces energy, and energy is required to maintain body temperature. So they're constantly burning. This is why their caloric intake for their size is so high. And then naturally they're also trying to put on so much mass and they're growing. So they're just burning everything. So they don't have anything left over effectively, very minimal. Be aware that little kids lack the ability to shiver. So just because they're cold doesn't mean they'll shiver. And our thermometers are okay. We don't carry hypothermic thermometers. So also take that into consideration if they start getting down into those lower temperatures, that you may not be as accurate as we're hoping. Same thing with the thermometers that go into the ear that we have. They oftentimes don't fit a pediatric population properly, so those may not be as accurate as well. Especially little kids, most parents have a thermometer. You might ask them to borrow it because it's probably in several cases going to be as or more accurate than ours. Significant hypovolemia and electrolyte derangements are common, especially with consideration to vomiting and diarrhea. Because they are so small, any changes in their blood volume can really affect them. So try and keep that in mind. It doesn't take a whole lot to deplete you even as an adult with vomiting and diarrhea. We've seen those people whose pressure's in the tank, and it's going to be the same or worse with kids. By that same token, remember they're going to compensate really well too. So as they're compensating, eventually they will crash. Also, be sure not to overwarm the child. So just try and keep them in that comfortable area. And parents are going to be pretty aware of how they've had them dressed as well. And you might just put just a touch more on if they're really sick, just to help maintain that heat, but you don't want to overdo it. Rely on their parent to give you as much information as possible. I think you guys know all this already. When you walk into a scene of pediatric calls, really take that second to look around. That first second you're in the door, you can really start to gauge how the child's interacting with parents, what the parents are doing or caregiver. If the scene looks like a mess, if it looks like there's a big mechanism of injury. So you can suspect, if it looks like the mechanism of injury is significant, that it's going to cause head and neck injuries as well, or could cause head and neck injuries. And we're going to take all precautions possible with these kiddos. So we had a call the other day with a kiddo who had fallen off the bed, but also had a seizure. And the question became, did he start to seize and fall off the bed, or did he fall off the bed and have a seizure? And ultimately, we're probably not going to sort that out on scene. You can take some clues into consideration and lean one way or the other. But just keep it in mind and take precautions as necessary. We're going to get into the pediatric assessment triangle, I think, on the next slide. It should take about 15 to 30 seconds. Have you all seen this before or yet? Yeah? Okay. So this is the pediatric assessment triangle. It's appearance on the left, work of breathing, and then circulation to the skin. So I think this is really helpful for all populations, but it's especially helpful in pediatrics. So while you're walking in from the door, take that second to just glance at the kid while you're asking mom or dad or caregiver what's going on, and take these things into consideration. I would suspect that tickles mnemonic would be on your test, or at least a chapter quiz. I don't expect you to walk into a scene and be like, all right, tickles, all right, tone, interactiveness, but we're all very aware of how kids should act, and you are going to take most of this into consideration just by looking at them. So I think those are all relatively self-explanatory. Is there any questions? Have you guys watched videos on the pediatric assessment triangle ever? There's some really good just survey videos that you can watch that are like, it brings in like a 30-second scenario, and you just look at the kid and sick or not sick. And it's a really good way to start to gauge pediatric population. So observe the child from a distance, delay touching them until you've developed that general impression. By the same token, you can have caregiver helping you. Really repetitive on that, but unless they're unresponsive or critically ill, take that time to build that impression. It'll tell you a lot about their situation. So kid on the right, sick or not sick? Sick, absolutely. Because kids hold on so long, a lot of these impressions are pretty easy. So, so this one just gets into abnormal level of consciousness, characterized by weird or inappropriate behavior, poor muscle tone, poor eye contact. Their general appearance is bad. It feels self-explanatory, but if you guys can remember this as you walk into a scene, it'll really help you. Work of breathing. So we'll touch on all these ones on the right real quick, but this reflects the child's ability to compensate for oxygenation and ventilation issues. Try and keep in mind oxygenation and ventilation, although related, are not the same thing. So abnormal airway sounds, things that you can hear from the door, especially in the pediatric population, talking about croup and stridor. If they seem excessively drooly, abnormal posturing, so it's not comfortable if you're short of breath to lay down on your back. So these kids are going to be fighting to get up. Accessory muscle use. Have you guys seen retractions before? So it really sucks. It sucks into the chest, in between the ribs. It's really noticeable. Head bobbing, nasal flaring. Nasal flaring is big in our adult population as well. And then obviously tachypnea. Circulation to the skin. So if you have a kid that's cyanotic, you're behind the 8 ball because they hold on again. But determine the adequacy of their cardiac output by their core perfusion. Modeling would be pretty concerning to me. But here's a good picture of it. I don't know if you've all seen it before. Pallor of the skin, mucous membranes may be the initial sign of poor circulation or the only visual sign of compensated shock. So has anybody checked mucous membranes on people? I do all the time. So you just pull their lip down, pull their eyes down, really get into those areas that should be wet. And if they're dry, then they're intravascularly dehydrated. You check and see if their tongue's furrowed. Probably been trying to shove fluids and things down them, their parents, if they were sick. So that may not be as great of an example, but you can look for it. So cyanosis, the bluish discoloration of the skin. This is a visual indicator of poor perfusion or oxygenation. Once again, if you see that, you're behind the 8 ball quite a bit in kids because they are able to compensate for a bit. Acrocyanosis, infants younger than 2 months old, so it's blue hands, blue feet, basically just peripherally shunting. True cyanosis is seen in skin and mucous membranes, and it's a late finding or shock, which is what we just talked about. And then once again, I think this is kind of funny. They have to put this in, but never wait for their skin to be cyanotic before you administer oxygen. And I think if we have to go over that, we should probably not be here. The patient's unstable, then start treating life threats. So A, B, C, D, E's, and transport. If they are stable, you can remain on scene and do a little bit more of an assessment. I feel like right as we walk in the door, almost everyone knows if we're leaving or not on a kid. So they tend to be either throw them in the ambulance and let's leave, or let's just calm down and slow down and possibly let parents even take them to the hospital. I think you guys are pretty aware of your ABCs. Yeah? All right. Questions online? We doing good? Perfect. If you suspect cardiac arrest, the order is circulation first. And that goes in line with new AHA standards. Airway, if the infant or child is responsive and the airway is open, then you assess the adequacy of it. If they are unresponsive or not breathing, then you can start moving into your procedures to open their airway. Breathing, calculate the respiratory rate, listen to breath sounds, check your pulse oximetry. Remember, we have those pediatric finger probes. Note the degree of air movement at the nose and mouth. Little kids will breathe through their nares often, so try and keep them clear. Assess the respiratory rate and effort. A lot of this a lot of kids is going to be looking at that specifically. How much effort are they putting into it, and how quick are they breathing? And then listening for abnormal sounds. As they begin to tire, retractions often become weak and ineffective. So just because you don't see retractions or because their rate is slower doesn't mean they're not sick. It means they're probably past that. And then bradypnea is an ominous sign that indicates impending respiratory arrest. If their heart rate starts dropping significantly, don't think it's because they're getting better, because that's going to take a little bit, especially if they were that far behind for them to catch up. If their rate starts dropping, I'd really quickly be puckering and trying to figure something else out. Circulation, first controlling the active bleeding, assess the pulse rate in skin. In infants, palpate the brachial pulse or femoral pulse. Children over a year, you can palpate the carotid pulse. And here's examples of all three of those. Note the rate and quality of pulse. This is a good habit for everybody on scene. I tell everyone that works with me that on a kid or an adult, you just grab their pulse while you're first starting to talk to them. Even if you're not actually calculating it, try and see if it's regular, try and see if it's fast or slow. We all check pulse rates enough that we have a general idea of where they're at typically just by feeling it. And trying to determine if they have a radial pulse is going to tell you a lot about their situation. Weak central pulses indicate significant hypotension decompensated shock. Weak or absent peripheral means that they have decreased perfusion to the extremities. If your central pulses are weak, really, really behind the 8 ball again. Interpret the heart rate within the context of the overall history of the patient, the pediatric assessment triangle, and your primary assessment. Capillary refill, really reliable in kids under 6, less reliable as you get older. But this is a really good way to determine if they're getting some perfusion down to their extremities. So color should be returned in less than 2 seconds. If it doesn't, then you can start suspecting things like peripheral shunting and not getting perfusion to your end organs and things. Pupils and your AVPU score. I think these are all pretty typical. Yeah. Here we go. So assessing pain in the pediatric population is difficult, especially because they're usually uncomfortable and crying already. This is where the rating of the faces comes in. So this is intended for kids, not for adults. So if they're crying, they can still tell you. But I don't know. I think we're all pretty well versed in this stuff. So. Pediatric assessment triangle requires that the caregiver removes part of the pediatric patient's clothing to allow for observation. Make sure you put it back on if you can, or a blanket or something, especially in the little kids. They can't tell you. Keep the temperature in the ambulance high. We should almost be uncomfortable. And sorry, but we have 5 minutes to the hospital. It is what it is. If they're hemodynamically stable, we already touched on this, but you can do your secondary assessment at scene. If they are not, then try and transport in immediately. Also, they want to touch on if the transport immediately if the scene is unsafe, which makes sense. If there's a significant mechanism of injury where maybe you're not seeing the results of it yet. As an example, I've seen a splenic lac that the kid seemed relatively fine right up until he started bleeding out. And then luckily we transported, because I don't even want to know what would happen if they decided to refuse on scene and he had just crashed a bicycle and took a handlebar to the gut. So, yeah. So consider the following when making a transport decision. The type of clinical problem, is it injury or is it illness? That's going to be less, it's still important to determine that, but it's going to be less important as far as determining your hospital location because we have one option. If they are a minor condition, there's no reason not to go to Kootenai, but you could transport into Spokane as well. But Kootenai can handle all of this right now. So, sorry. Okay. Obviously, if they're critical, we're going to the closest hospital anyway. For you guys, I guess that could bring Valley into the option at some locations, yeah? Maybe? Okay. For anybody at Northern Lakes, especially if they get up into Spirit Lake and Blanchard area, they can consider Newport because it's significantly closer, but know that the physician is not always there. We can mount a car seat to the stretcher. We also have the PD car seats that we can put on the gurney. I prefer those because I just feel like they attach better and they fit better and everything feels more secure to me. That'll be your guys' decision as the provider on scene. If you're going to install a car seat, try and follow the manufacturer's specs. They're relatively straightforward, but they also seem to always have something done wrong on them if you check them. So, it is not appropriate to secure a car seat if it's going to interfere with splinting or if they're arrested, being cardiopulmonary arrest, if they need to be immobilized on a longboard, etc. There was a theory for a little bit where the car seat kept them in a neutral inline position, and so we should just keep them in that, and that's not really the train of thought right now. So, especially if the car seat was involved in an accident, at that point they're supposed to be replaced. So keep that in mind. When history taking, provide emotional support. Speak with them appropriately. Use appropriate terminology. If they're younger, much smaller words. As they get bigger, respectful words. Allow sick and injured children to express their feelings. It may take an extra minute, but as long as they're not critically ill, just allow them to work through it. Investigating the chief complaint. Your approach to this is going to depend on their age and who's around. If it's a sensitive issue, they may or may not want their caregiver there. And I know we touched on this earlier, but especially in the female population, talking about possible pregnancy, in either population, talking about their sexual activity, illicit drug or alcohol use. I'll usually take the opportunity as soon as parents are not around, because we're loading in the ambulance or things, to try and get these questions out of the way. If there's cops around, they're going to be uncomfortable about it, but you can usually talk them into it as long as it's just you guys. So. If the parent can't go to the hospital, get a name and phone number. And I'd also recommend, especially for all of us guys in here, if it's a female, try and have a second provider with you. I know we have the cameras, but I don't think anybody wants to take that chance. So we have at least on our shift, it's just common standard. If it's a younger female, then somebody rides in. And we've already touched on this, but you guys know decap PTLS now, yeah? Perfect. Probably several times over. Oh, here's a line about infants, toddlers, and preschool kids starting at the feet and ending at the head. So there it is. Oh, well, I don't know if it'll be on your test or not, but I wouldn't study it too heavily, I guess. We're going to get into all these things, but here's a list of the physical examinations that it may include. I think maybe it doesn't touch on them. So head everywhere behind the face. Remember that they're larger in kids, checking for hematomas and things. Remember that their subarachnoid space is smaller, and so if they do have a bleed, it's going to fill up quicker. Pupils, nose, ears, mouth, their tongue is proportionally larger. They tend to breathe out of their nares, so keep them clear. If you see fluid leaking from their ears, suspect a ruptured eardrum or ear infection. Looking at battle signs, or you can do that halo test we talked about and see if there's any cerebral spinal fluid. chest and back being much more pliable, suspect injuries below it. And then obviously auscultating your lungs. Same thing with the abdomen. Extremities are still more pliable, but kids tend to break arms and legs because they do crazy things. And then your level of hydration. And there's a funny picture in here somewhere of them. I think it's when Nico's teaching you guys, I'm not sure, but they're like pulling the whole kid's head back. He looks like an alien. Like his skin like pulls like this far. So vital signs, some of the guidelines used to assess adult circulatory status have improved limitations or have important limitations in the pediatric population. So know that their heart rate varies, and we touched on that already. Their blood pressure is usually not assessed in children younger than 3. I know that almost every EMS book I've read says that, and I also know when I pull into the ER, they want to know what the blood pressure is. So take it with a grain of salt. You can usually get one on their leg. Yep. Yep. So every EMS book I've ever read is like, we don't do it under 2 or 3. And when I get to the hospital, it's the first thing they want to know. So use appropriate sized equipment. Braslo tape is going to be really important, especially if we're setting up for code stuff. Trying to get the right size on all these kids. Luckily, we have those PD bags now, so everything should be size specific, but know that you may have to alter in a weird situation. Just be prepared for it. Rapid respiratory rate may reflect high fever, anxiety, pain, or excitement. Uh-oh. I'm pushing the wrong buttons, Chief. Okay. They want you to count respiratory rates for 30 seconds. As long as they're not irregular, I think we can do 15 seconds and get away with it. However you guys want to do that is fine by me. But for your book, I don't know if it's going to specify that or not, or if that's just giving you an example of how to do it. It says you can consider taking an apical pulse. If you're having trouble getting brachial pulses on the little baby, this might be an option, especially if they're really sick and not real interactive. But if they're crying or they're wiggling around, you're going to have a really hard time doing that. So, perfect. All right, let's take a break. I want to go. All right. So we'll start back up. Sorry, I didn't realize I stopped you guys right before the end of this section. I apologize. We're going to reassess the child's condition and situation. So every 15 minutes for a child that's stable, 5 minutes if they're unstable. You might actually consider, if they're really unstable, bumping that up in real life to like 3 minutes. And your monitor can take them every, I think even 1 minute if you want it to, but at least 3 minutes because I've done it. So too many blood pressures is going to start giving you inaccurate trendings, but definitely reassess their pulse and respirations frequently, which I know we're subconsciously doing as the call goes on. We're probably not documenting it, but really make that effort, especially in kids, because if they drop off, then you want to catch it right away. So interventions, always consider getting help from a parent or caregiver. If you're doing advanced interventions, you may just want them sitting near you because they're going to be pretty frantic, but it's going to depend on the kid's level of consciousness. And there we are. All right. So you may administer medications to the population, and sadly most of these not in this county, but definitely know them for your test still. So we're going to touch on most of these as time goes on, but we'll hit them real quickly. Albuterol is obviously a neb. D25, and then it actually gets down into D10. D10 is much more appropriate for the little bitty PDs. There's actually, this is not for your testing knowledge, but just as a side note, there's some debate going on whether or not D10 or even D5 would be more appropriate for most diabetic situations because it's so much less necrotic. But it also takes longer. So, epinephrine, glucagon. Remember, in your pediatric population, if you're going to give glucagon, that they don't have glycogen or they don't have as many reserves, and it takes quite a bit of time for it to be effective. So if you're going to give it, definitely just transport, and then if it works, it works, and if it doesn't, then life goes on, and they'll fix them up at the ER. Glucagon is not a bad option for us in kids because we have a hard time getting that IV like we talked about. So this is a pretty good option if they have reserves to bump their sugar up. We do not have nitrous oxide, but know that for your test. Obviously, we have oxygen activated charcoal. I don't think it's common practice anymore, but I've heard people putting activated charcoal in like chocolate milk because then the kids will drink it. So whatever you got to do to get them to get it down, we also don't carry that, so it makes a mess. Infants have a limited ability to compensate for respiratory insults. If they can be resuscitated, if you can get on the respiratory status early, you can sometimes catch them before they go if they're pretty advanced in their respiratory compromise. So once again, I'm going to hammer it with you guys, and the book's going to hammer you on it, but airway, airway, airway. Signs of respiratory distress get into pallor, irritability, respiratory rate retractions, abdominal breathing, nasal flaring, stridor, grunting, mild tachycardia. I think we've almost seen this exact list already. So I'm going to touch on you guys' repetitiveness of your slides again. Patient experiencing respiratory failure can no longer compensate. So this is talking about they've moved from distress and their ability to compensate is no longer keeping up with them. This is where they're going to start having more hypoxias, where they're really approaching the end of that compensation curve and starting to drop off. This can happen really, really quick in the Peds population. It happens quick in the adult population, but kids will literally just dive off the end of the diving board. So mental status will change, skin color changes, respiratory rate. Their effort is going to increase initially, and then approach the end of failure, it's going to start decreasing. Auscultation, so stridor, wheezes, crackles, diminished air movement, and then obviously their pulse rate and sat. Respiratory arrest means the patient is not breathing spontaneously. So that's good to know. Definitely start administering the BVM. This is where we're taking over ventilations. Prior to that, if we were on scene, we should be assisting them with the BVM. Try to not let them jump off that end with us not helping them. They may not let you have the BVM in their face initially, but as they get more into that failure, they're not going to be conscious enough to be aware of it. And then allow them to assume a position of comfort if they are not in arrest. Supplemental oxygen, ECGs. You guys are doing 4 leads, yeah, in class? No? Okay. IV access, and then the airway should be managed, it says, in the least invasive way possible. So sometimes I believe in being aggressive with most of our patients and getting ahead of things, and sometimes being aggressive means not intubating if you can get ahead of it quick enough. Sometimes it means having the willingness to pull that trigger and walk down that road. So just keep that in mind. The more aggressive you guys are up front, you may prevent stuff on the back end. Signs and symptoms of upper airway emergencies. So we're going to be strictly talking upper here, and I'm curious, what does your book classify as upper? Because I've always talked about above the vocal cords, but it seems like it goes lower. Okay. Okay. So it's one of the slides is just confusing then. All right, so upper airway emergencies, we're talking about foreign body aspiration and obstructions initially. So anything they can fit in their mouth is certainly an option that they will fit in their mouth. They all have oral fixations, and everything needs to be tasted. So coins, balls, coins we get lucky with a lot. They can definitely occlude an airway, but they also tend to swallow them. It can cause a problem for the kid, but it usually doesn't cause a problem for us, other than they're going to get transported, possibly with us or their parents. Most of the time, they just have to check their poo for a few days and see if it passes. It can definitely cause them some internal trauma. If it gets into the airway, it's going to cause us more issues. The toys and balls and things tend to be a big issue. One, because if they end up choking on it, they're hard to get out because they're slippery and they're round and they suck. And this becomes really dangerous for kids, especially like bouncy balls and things. Sometimes they're really hard to get out of their airway. Same thing with food. Kids that don't have a lot of teeth and are chewing on meat and things and start laughing, they're all ADD, so they can't focus on one thing at a time. And like I said, I don't know if it's a sign of intelligence or not. My daughter sticks all of her food in her mouth first and then tries to chew, so we're constantly sure she's going to choke. Anyway.
I'm pretty sure that's a sign of intelligence.
Is it? It's efficiency, right? Look out for blood, vomit, secretions. As they get more sick, they're going to kind of get that mucus in their trachea that they just really hate. Anything that's rolling down the back of their pharynx, if they have a bloody nose, the clot can roll down. So just be aggressive with their upper airway. Especially if you guys, well, especially always, but in addition, if there's no medic there, then you're going to have some limited ability to get in there and try and do anything about it. And I feel like even at the medic level, we're pretty limited in our ability to clear an airway anyway. So, yeah. If it doesn't completely block the flow, they may still be able to breathe adequately on their own. Give them some supplemental oxygen and stuff may be able to flow by. By that same token, if you suspect that they're partially choking, know that whatever they're choking on may shift into place and become a complete obstruction. Clear the airway immediately if you see any of the following. Remember, we don't do blind finger sweeps, but we can definitely suction and things. If there's ineffective coughing, they have an inability to speak, they're cyanotic, if they're unconscious. There's only a handful of reasons for a kiddo to be unconscious, especially if they haven't been sick. So you start thinking trauma and choking pretty quick. And then if an infant is responsive, or if they are not responsive, you can perform your back blows and chest thrusts. If they are older than 1, then we are going to be doing abdominal thrusts or the Heimlich maneuver. Never using finger sweeps, and chest compressions are still recommended because it will actually build up pressure within their thoracic cavity and possibly spit out the obstruction, as well as we're still circulating whatever oxygen's in there if they do arrest. So. Anaphylaxis is big in the pediatric population because they don't always know that they have an allergy yet, so they don't necessarily know to avoid it, or they don't know to be looking for it, or something slides in they didn't expect. So like peanut allergies and things, kids may not know there were peanuts in it, and next thing you know, they're reacting. Adults tend to be a little bit better about trying to manage those things, and if they do feel like they're having a reaction, they're usually a little bit better about having an EpiPen or calling early or going in. Anaphylaxis is not always as quick as people suggest it is. So the second the peanut touches their tongue doesn't mean that they're going to completely swell up, but it does mean that they need to be managed, and some people are going to react quicker than others. Child with severe anaphylaxis may be in respiratory failure or shock when you get there. And then the pediatric assessment trial may reveal an anxious child. Primary survey will usually reveal hives, swelling of the lips, oral mucosa, stridor, wheezing, diminished pulses. Any, all, or none of these symptoms can be there initially. Sometimes your anaphylactic calls are going to be 100% textbook, and sometimes they make no sense until you realize they're getting shocky. One of the weirder ones I had was a gal who had no hive, she wasn't diaphoretic, she had no lung involvement, but she knew she was allergic to peanuts. She had become aware that she had eaten peanuts, called us, and then seemed fine right up until her blood pressure dumped, and she had no other outward signs. So just repeat and reassess, listen to what they're saying, and try and take all that in. Gold standard for treatment of anaphylaxis is epinephrine, as well as Benadryl followed by that. If they have a known allergy, that's better. If they don't, you can still suspect it. And I think we all know how Epi works. And Benadryl, good to go. Sweet. All right, croup is an infection of the upper airway, really common in kids 6 months to 3 years of age. Mostly occurring in the fall and winter months. They get that typical stridor seal bark. It's really noticeable. Humidified oxygen is really helpful. A lot of parents will have stuck their kid in the shower with some steam building in there. They usually have a hard time sleeping. They're usually real fussy and upset and uncomfortable. It does cause edema of the supraglottic space, and if bad enough, can cause a complete obstruction. More often than not, it seems like croupy kids are kind of just those sick coffee kids, and we look at them and they're sick and they need to go, but they're not real bad. With that being said, sometimes parents are going to wait too long, and we are going to walk into that one that's really, really, really sick and should have been at the hospital a long time ago. Be concerned about critical airway obstructions. If the kid's really sleepy or obtunded, then they're probably fairly hypoxic as well. Just assume it until it's proven otherwise. You might also check on what kind of medicines parents have been giving them. So sometimes parents choose the wrong med for a kid that age. Allow them to assume the position of comfort. Call early for ALS if you need it. And then be willing to assist with ventilations with BVM earlier than later, like we already talked about. Epiglottitis used to be commonly a pediatric emergency. We're actually seeing it more in the adult population now than the pediatric population. But the pediatric population is the one that has a lot of potential for compromise for us because of the swelling of the epiglottis and some of the surrounding areas. So these kids are really, really drooly, having a hard time breathing. Hopefully they're not cyanotic and too obstructed by the time we get there. These have, thanks to vaccines, epiglottitis has dramatically reduced, but we're still seeing it. And then the other take-home message from all this is with the anti-vax movement right now, we're seeing a lot of these issues rebuild, as you guys know. So just because it used to not be common doesn't mean we're not going to start seeing them again. And just because you were vaccinated doesn't mean we're not going to see it in that population as well now. So. Symptoms progress rapidly. We actually had one of these 2 weeks ago, I think. The first one that I've knowingly seen, which has been odd. I feel like I keep seeing everything recently that we're talking about. But it was actually an older gal, but she had all the textbook symptoms of it. Luckily for us, she had been diagnosed. She was like 80-something. She had been diagnosed a week before. Somebody just put a comment up there. And so when they had initially ran on her, Georgia's. Travis asked if Benadryl is an advanced level, and it is not in our county.
I'm looking to see if I have the advanced breakdown that's got sent state.
I don't believe it is. I could be wrong. I don't believe it is, but many of these parents may have given it before we got there. And it's another one of those medicines that is relatively benign that I kind of wish it was at the advanced level, because it can really help a lot of these kids. And if you can buy it over the counter, I feel like then you guys are qualified to give it. So, but that's for a conversation much higher than me. Right. Sorry, Dr. Chun. Anyway, so this older gal that had epiglottitis, she was experiencing a lot of shortness of breath, but when they're listening to lung sounds, they're not hearing anything. Said maybe some stridor up top, they're not sure. They weren't really sure where to go with her manager initially, until they started walking down the track that she had an upper airway obstruction. For us, racemic epi is going to be our go-to. It's kind of our only option, and it's that or intubate. So if they do get intubated, they're going to be tough intubations usually, but hopefully earlier than later. So. Mm-hmm. Most of these kiddos, especially in our transport time, can be managed appropriately with just some oxygen and maybe some racemic epi and things. But if we get there and the kid is obtunded, then it might be a different story. So, questions? Nightmare patients. Yep. Like I said, this used to be a pediatric disease. It seemed like you didn't see it very often in older populations, and now, talking to some of the ER docs the other day, it sounds like they see it more in adults than they do in peds. So, I am not positive why they do not want you to attempt IV access in these, other than maybe there's nothing you're going to be giving them for the emergency up until the paramedic level, and I'm not sure. Chief, do you have any insight on that? I kind of questioned this while I was going over the slides. I would say if they're walking down that range where they're really compensating, that you should get IV access if you can, because they're probably going to get intubated if it's that bad.
The only reason I'm going right along with what you're tracking, the attempt of an IV in a child that's building up is going to heighten and increase epiglottitis.
Right.
When our goal is to do everything we can to calm.
Right.
But
that was my exact thought.
You nailed it. If we're at that point where we're at the crossroad, we have to.
So for everyone online, Chief was saying that most of these patients, it's going to be about calming them down and keeping them as non-stimulated as possible. That way they can manage their own airway. But if you reach that breakover point, then you don't really have a choice. And if we wait too long, then we really mess with our ability to do things. So it's definitely a balance, and you guys are just going to have to find it. Before your test, no IV access. All right, lower airway emergencies. So we're talking about the vocal cords and down. Signs and symptoms include wheezing and crackles. A lot of kids have asthma. So asthma is going to relate similar to an anaphylactic reaction that had lung involvement. It's really similar to a little bit different pathophysiology, but think of your COPD patients, very similar. They can breathe in, they have a hard time breathing out, they're retainers. So acute spasm and inflammation of the bronchioles. Sometimes they'll know what their triggers are, sometimes they don't even know what a trigger is. At this point for us, it's relatively irrelevant, but sometimes it's good education for the patient or the family. Sometimes these patients, because they have bad anxiety or they have bad asthma, it's also an anxiety call or an anxiety call. So do your assessment. We had the pleasure of having, I was talking to some of the guys in class earlier, we had a patient with a pulmonary embolism this week that an initial presentation, if you were looking at her from the door, she looked like an anxiety call. But you still got to do your homework, and you still got to check and make sure before you make that determination. So, especially in these asthmatics, sometimes you'll hear them wheezing, sometimes you won't, but really get your stethoscope on them, get an end tidal on them, and take a look before you make a decision one way or the other. This occurs when hyperactive bronchioles become narrowed.
Which
Yeah, totally spontaneous. No
How old?
60 something.
That's old.
Yeah, so old.
Christ, she's still breathing.
All right, so asthma, much like an allergy situation, if you have your trigger, your body releases histamine, and then histamine causes us all these wonderful problems because it thinks it's helping itself. So that's why you get Benadryl, it's an antihistamine. And then some epinephrine will reverse some of the effects of the histamine. Initially, these patients are going to be hypocarbic because they're breathing so fast, and as their breathing becomes worse and worse, they will become hypercarbic because they're not able to exhale as well. Talking about end-tidal, you should see the shark fin waveform. If you guys, I'm sorry, Pete, I know you already told me, are they doing end-tidal? Okay, so end-tidal is amazing, and I think we should use it more than we do. Most of the time, it's not going to tell you something you don't already know, but it'll save you several times so that you'll think it later. Anybody at County should talk to Maurice about end-tidal. He's pretty well versed in several things about it. But when we get into waveforms and values and things, even if you don't feel as well versed in it, the RT at the hospital is. And you can start talking to them about stuff. You can tell them this is where they started, this is where they're at now. So as an example, on that pulmonary embolism call the other day, which I realize is not a Peds, but just a side note, her end-tidal was 8. So there's not a whole lot of good reason for an end-tidal to be 8, other than she's not perfusing across the membrane. So keep those things in mind. Sometimes they have that thing that throws a big red flag for you. Also with that, some of your, probably not as much in your younger populations, but your older populations with COPD and asthma, expect that number to be really, really high because they'll be retaining. So as the asthma patient breathes off initially and they're worked up, that number drops. And then as they lose their ability to compensate, it raises back up. As it raises up, they become acidotic. As they become acidotic, they can't hold on to oxygen, and it's a really nasty spiral for them. So signs and symptoms of acute asthma: child sitting up in a preferential position, probably be tripoded, be breathing pretty quick, they're wheezing, they're tachycardic, they're pretty agitated, they get that prolonged expiratory phase. You might see them with some pursed lips, they're really breathing out. Administer oxygen, so if it's pretty minor, some oxygen will probably make them feel a whole lot better. If it starts getting more progressed, they're going to need beta-2 agonists and things to help reverse some of those effects. If they've been prescribed a meter-dosed inhaler, you guys can help with it. So that's certainly a great option before ALS gets there. Most of the patients that use their inhaler at home don't use it properly. So you're supposed to leave that medicine in there for at least 10 seconds, and usually they're so worked up they can't hold their breath for more than 2. So if they tell you they've taken 5 or 6 doses, it may not have even gotten 1. Buterol is administered through a nebulizer. The child is showing signs of respiratory failure. Begin assisted ventilations with the bag mask device and 100% oxygen. If you can get the kid to let you assist them, then they're either probably an older kid or they're approaching that failure point rapidly. Intubation may be necessary. These are kids that you want to get on top of early. Status asthmaticus, you guys know about that? Yeah. So say whether it's status asthma, status seizures, they're real bad deals. In the hospital, they have a hard time breaking these asthma attacks if they approach status. It's really difficult and really dangerous for the kids. Definitely likely going to be intubated, likely going to do a stint in the hospital, at least overnight. or a very long ER stint, one of the two, but they become very dangerous for them. Symptoms include respiratory failure, secondary to severe hypoxia, acidosis, and physical exhaustion. And like we just talked about, as they become more hypoxic, they become more acidotic, then the body loses its ability to pick up oxygen, and it becomes a really bad spiral for them. Right, pneumonia, another lower airway disease. Children with pneumonia typically have a history of a cough or a cold or an airway infection, likely but not guaranteed, and not everybody's the best historians, as we know. So take everything with a grain of salt. They should have a fever. It's usually caused by a virus. If it's really bad, you're going to get into the same ventilatory issues that you saw with asthma, except for it's going to be crackles and actually, that's a bad statement. I'm going to retract that statement. They're going to have ventilation issues. It's not going to be the same as asthma. But they're going to be rapidly breathing. They'll be grunting. They may have some wheezes, but they should have crackles. One of the things with pneumonia is sometimes you can localize those crackles to a lobe. And that's more of a, it gets you out of thinking in your older population that it's not CHF or something, that it's more of a pneumonia. Hypothermia or fever, and primary treatment is going to be supportive, as long as they don't crest that peak and go into an arrest or a high failure. Vascular access is generally not indicated for the same reasons as epiglottitis. Once again, if they start approaching that area, then you guys should try and get an IV while you can. Bronchiolitis, not to be confused with bronchitis, both common in the pediatric population. This is similar to bronchitis, except for it's down in the bronchioles, so much lower airway, often caused by RSV. Lots of little kiddos get RSV. They usually get hospitalized for it. It can be a bad virus for them. Bronchiolitis occurs in the first 2 years of life, more common in males, and I'm not sure why. There it is. Widespread in winter and early spring. So they become inflamed, they swell, they fill with mucus. Those areas that get filled with mucus can become easily blocked. Along with the virus, just like if you had the flu, start looking for signs of dehydration, fever, lack of appetite, those sorts of things. Treatment is going to be supportive, as long as they don't crash. So, and let me check the slides real quick. Let's see where we're at. All right. For everyone online, we're going to go a little bit over halfway. I don't know if I told you guys that. Nico's going to pick up on Friday. Pertussis is a potentially deadly disease. This is also called whooping cough. Once again, was almost completely eliminated, and now we're seeing it come back into the population. Coffee, sneezy, runny nose. Symptoms are really similar to a common cold, but it's really, really contagious, and it ends up really bad for a lot of these kids. So, I know we had some cases in Spokane, I think last year or 2 years ago. I don't know if they ever made it into Kootenai County. I never heard. But we potentially very easily could see some of these cases. As the disease progresses, coughing becomes more severe and it gives this distinctive whoop sound. And it's usually heard during the inspiratory phase. Keep the airway pain transport. Once again, most of it's going to be supplementary. We need to be really good about our PPE in a lot of these patient populations. So masks and things. I don't know how county does it. I think EMS as a whole is not great about throwing a mask on and taking some of those precautions like the ER is. or the hospital in general, and we probably should be, because it's only going to take a couple of these cases where somebody gets sick, and it's going to be real sad. So, and you don't want to bring that stuff home with you. So, airway adjuncts, use the right size, use Broslow tapes. We have the individual sizes for weights now as well, so a lot of this should be sorted out for us, but just keep an eye on it. Oral pharyngea OPAs, let's go with that. Used for pediatric populations who are unresponsive and in respiratory failure. Should not be used in responsive patients or those with a gag reflex. These are all the standard OPA rules. Please don't just keep jamming it down. If they've ingested a caustic or petroleum-based product, try not to use an OPA. Just do manually open the airway. If tongue blade is not available, point the airway tip toward the roof of the mouth to depress the tongue, and then avoid injuring the hard palate. NPAs are rarely used in infants younger than 1. They should not be used in any traumatic situations that have involved the head. Or if you suspect that they could have had maybe most of the damage was to the chest, but it was a big mechanism of injury, you should probably just avoid the NPA in general. I think we know how to insert those, so we'll move on. Oxygen delivery devices are going to be determined by your patient's age, their acceptance of how you want to deliver it, and their current condition. When using a BVM, we're just looking for chest rise and fall. They don't need the whole bag. Case in point, there's actually some agencies starting to use pediatric bags on the adult population because we as EMS overventilate. And we're really good about it while we're in a skill station or while we're focusing on ventilations. But this first time that we look away and we start focusing on anything else, our rate tends to go up quite a bit. So that's not just us, that's all healthcare providing. But just know that, and I think I said this in one of my other classes that I taught with you guys, that if somebody is airway, that's their job. As long as you have enough people to do everything else, their job is just airway, and let them manage it appropriately, especially in kids. If they manage it appropriately and stay on top of it, then all your other problems get better. Here are your different devices that they suggest you can use and the concentrations to use them at, and I think we can move on from that. Questions? Sweet. Blow by oxygen, handy little idea. You can make it out of a cup. We talked about those rebreather bearers. Even just putting a mask near their head will do quite a bit. If you can get the nasal cannula on them, that's great. Consider end tidal on most of these kiddos. You have your non-rebreathing mask, you have your bag mask device. I think we're all up to speed on those. 2 rescuer is usually more effective at maintaining a tight seal. So once again, Peds, airway, focus, repetition. Right. Cardiopulmonary arrest. Most often associated with respiratory arrest in kiddos or trauma, usually respiratory. Children become hypoxic and their heart slows down. They become more bradycardic. The heart rate will beat slower with each beat until no pulse is left. I don't know if you guys have ever seen this on the adult population. They tend to, they'll do it as well if they get hypoxic, but kids will, because they have a really strong heart and they don't have this big heart compromise usually, their heart will keep beating until it just slows down and stops. So you can watch it. You can watch it during like intubations, not on kids. And we don't want to see it go all the way down, but you can actually see the heart rate start to drop when it gets too low. So you will see this in some of your, if you pay attention close enough during some of your codes and things that happen, like somebody who's right pre-arrest, you can see their heart rate start to dip. We don't want to see it in anybody. We especially don't want to see it in kids. And hopefully we can get ahead of it. The overall survival rate from cardiac arrest in the pre-hospital setting is low in general. It's low in children too. If anybody's going to bounce back, kids tend to do pretty good. But they have that big compromised issue for anoxic injuries because they need more blood flow. So keep those things in mind. And it actually says at the bottom too, many of those who do survive have permanent brain injuries. Shock. Develops when the circulatory system is unable to deliver a significant or sufficient amount of blood to the organs in the body. Children can compensate longer than adults, and then hypotension occurs quickly and unpredictably. So these are why you want to be measuring blood pressures constantly, because it'll get away from you before you know it. Really watch their skin color, make sure it's not changing. Signs of shock in children is tachycardia, poor cap refill, mental status is decreasing. Remember, that's appropriate for age. Common causes include hypovolemia, sepsis, allergic reactions, poisonings, even a kid who's been vomiting for a bit because they don't have that same, because they have a fragile capacity, they can really put themselves into a decreased perfusion state pretty easily. Pediatric patients in shock may not demonstrate a fall in blood pressure until shock is severe. So remember, their heart beats really, really well, so it holds on for a long time and they compensate well, and then it drops off. So you may look at them and say, oh, your blood pressure's good, and then your next blood pressure, it may be in the tank. Really be looking for your physiologic changes on them, so pulse rate, skin color, diaphoresis. Value of blood pressure is age specific, and low blood pressure is a sign of decompensated shock. They require oxygenation, fluid administration, and immediate transport if they're in that stage. I would suggest even in the compensated stage, they need all of that as well. Otherwise, they're going to progress to decompensated. Determine when the signs and symptoms appeared and whether any of the following has occurred. So this is where parents are going to be really helpful in your younger population. How many diapers have they been through? Are they drinking water? Does it seem normal? In a really severe state, do they have no tears? Do they have depressed fontanelles, changes in the level of consciousness? Those are things you can see, but parents are going to be your big historian on what they've been acting like recently. Time should not be wasted performing field procedures. Anaphylactic shock is a common form of shock we'll see in the pediatric population. So it's a multi-system response to an antigen. I know we already talked about a lot, but common causes are insect stings, medication, or food. The airway and cardiovascular system are important sites of this potential life-threatening reaction. So you're going to have, they are respiratory, but this is one area where their cardiac's going to cause you some problems too. Because allergens hit the whole spectrum. So luckily, epi works on the whole spectrum as well. So just try and get it early, earlier the better. If you're starting to walk down the road, we all know the signs for shock and protocols and things, but if you're suspecting shock, or you're suspecting anaphylaxis rather, really have that epi early or ready to go. Most of the kiddos are going to have some of those side effects that an adult would with epi. They should be able to handle it pretty well. So as long as you dose appropriately, there's not a lot of negative consequences, especially if they're like borderline shocky and you're not sure. You don't need, I'd be aggressive with it because they can handle it. So, and you definitely don't want to find out you were wrong and wait until they are more progressed and now you can't. You can still give epi, but now you can't do other things. Stridor and or wheezing, increased work of breathing, altered appearance, restlessness, agitation. Sometimes they'll get that impending doom. Have you all seen that? When patients transition from anxiety to impending doom. Sometimes people are just really anxious, but that impending doom usually is pretty obvious. And it really should set something in you that says this is serious. Hives are usually present, but not always. So keep that in mind. Kind of a slam dunk if we see them, but they're not always going to be there. And I think we know all that. All right, bleeding disorders. Hemophilia is found predominantly in males. Any injury is a serious injury because they lack the ability to clot. So anybody who's and I've actually never met a hemophiliac, but anybody who has a hemophiliac injury, or they have an injury and they have hemophilia, they need to be transported. Intravenous access is not performed as frequently in children as in adults. If you're not going to start an IV on a hemophiliac kid and they're bleeding quite a bit, I have a hard time understanding that, other than you don't want to work them up too much. But once again, it's going to be that balance. And it's going to depend on how much they're bleeding. Remember, they have a larger blood volume for their size, but still smaller volume than us. So you're going to have to try and get ahead of them still at some point, if it's that bad. If they've got a cut finger, it may be different. But if they're actually bleeding, then I guess weigh out your ability in the situation. Here's your different size catheters for Peds. They don't recommend going above a 20, which I would say is accurate. When you get into the older kid population, obviously you can just look at it and tell, but these younger kids, when we're not good at IVs in the Ped population and their veins are tiny in general, don't ruin the site trying to get the biggest thing possible. Try and get access first and then deal with it later. Fluid control is important. Definitely use a Buretrol. You guys, his book says 20 per kilo. Some programs are suggesting 10, depending on age range. But for your test, know it's 20, and I think that's going to be appropriate for our protocols and situations as well. And then constant reassess. IV locations. If you're going to start an IV, especially on a younger kiddo, try and have an arm board or something to secure it afterwards. The last thing you want to do is finally get an IV and then have them rip it out. So lots of securing. Choices for IVs, especially in the very young kids age range, because they have so much fatty tissue and things in their arms and legs and they're chunky still. Yeah, you're going to be looking at a lot in their hands and their real lower legs. You can use a pen light to illuminate the veins on the back of the hand. Definitely helpful. I would imagine, I've never tried it, but I'd imagine some of our higher lumen bulbs would probably do the same thing now. So it might be something to try if you end up in that situation. They're coming out with some pretty cool IV stuff, but I suspect it's going to be a long time before we see any of that technology. So. IOs. IOs, if you've never done one, can be a little bit anxious. And then you realize your first one that they're not that bad. Pediatric IOs make everyone pucker a little bit. 1, because we don't do it, and 2, because of the growth plate, and 3, because you don't want to go too far. And we've got this balance that we're trying to pull. If they need it, they need it. And that's kind of the end of the story on it. Be careful. Know your anatomy. But also, if you need it, be aggressive with it. Use help if they have any sort of painful stimuli. Have somebody else hold the leg so you don't mess it up. And then definitely secure it. I know most of our IOs stay in, but the last thing you want to do is drill a kid and have it come out. So IO infusion is contraindicated if a secure IV is available, which makes sense. So we don't need to drill somebody if we already have access. And if a fracture exists in that area, you can't put an IO there. So sadly, for not all, but a lot of our patient population, as far as Peds, it's going to need an IO, a big percentage is trauma. And so you may lose your IO access. And we just talked about that. Do we know why we don't want to give them too much fluid?
Less volume.
Yeah, we don't want to overload them. So we don't want to overload adults either, but they can deal with the expansion a little bit better. So just keep that in mind, that you really want to. I think we have a bad habit sometimes of just starting an IV and running it, and then we look up later and shut it down. And that's probably not the best form of treatment in a Peds, especially. So. I think this will be our last slide. So if your fluid volume is insufficient, it will not be effective in treating the child's condition. So that's 20 mils per kilo, reassess, repeat if needed. But also don't overload them. So as with everything, it's a balance. Be constantly reassessing them and go from there. Questions? Any pediatric conditions you'd like to talk about? You're going to get into more of them on Friday, but no? Online world, are we okay?
Maybe you can talk more about going back to respiratory rest type of situations. What's your breaking point from BVM to Metabolic Airway?
As far as going from just assisting to like an iGel. So breakover point, somebody said yes. Do we know what they said yes to? Breakover point for me, you're not going to put an iGel in while they have a gag reflex, so they're going to have to be pretty unconscious at that point. If they'll take an iGel, I'll put it in. That's my theory. So if you can get an OPA in, then I'm going to put an iGel in, or an Innovate. But for you guys, definitely get that airway in to secure as much as possible.
Would you say the same with epileptitis?
I'd probably try it if they were unconscious. But you're going to have a really difficult time ventilating them regardless if they're unconscious from epiglottitis. At that point, you're kind of hoping. Yeah, it might be difficult. You could cause damage, which is going to cause you more issues. So trying to distinguish that it is epiglottitis in the field is difficult. And I would just work off the fact personally that they're in a respiratory arrest situation and go from there. And if it works, it works. And if you try to ventilate them and it's not working, then pull it and try and figure out another means. We have other options at the ALS level, so get that coming early. And then the reality is that if you put in an iGel and it's not ventilating, you're probably going to have a really hard time bagging them as well. So it's a bad situation to be in, for lack of a better way to describe it. Can't think of anything off my head. You could try and reposition them. So the epiglottis being a little bit floppy, if it's sealed up and they're unconscious from that, then you may not have a lot of luck with it, but if you can reposition them, maybe it'll droop a little bit different and get it in there, but you're kind of in a hard place. Definitely suction as much as possible and look for any damage if you do put an iGel in. So if you cause a tear or laceration or anything, or you pop some blood vessel, then just be ready to suction that. But if they're in arrest, I wouldn't hesitate to put it in because you're already dealing with a bad situation. So, did Robert say anything else? He just said yes.
You'd ask everyone to give it.
Okay, cool. Anybody else? No? Okay. Perfect. Have a good day.
Continuation on Friday.
Continuing on Friday. I think this is the last time I'm teaching, but if you guys have any questions, feel free to ask along the way. Happy to help with anything I can. I think I have a skills day with you, but I think that's it. So, good luck. Happy reading. All right.